Hi, this is Dr. Michelle O'Donoghue reporting from Medscape. I'm at the ESC Congress in London, and I'm joined by Dr. Gilles Montalescot. He's a professor of cardiology at Sorbonne University. And one of the more interesting and perhaps surprising to some results that were presented at this Congress were the results of the ABYSS trial. This was a trial of beta blocker discontinuation. So before we get into the results of ABYSS, let's maybe take a step back and think about setting the stage for beta blocker research. Because I think for many years we hadn't seen much in this space. What did we know about the benefit of beta blockers after MI or for patients with stable coronary disease before this?
It's a very good question. Clearly, the studies that we have with beta blockers are old studies, old randomized studies, even before the era of mechanical reperfusion. What we have seen later on is big registries suggesting that in this kind of patient, very, very much stable patients, you may question the role of beta blockers for coronary prevention. And it's very tempting for the physicians in everyday practice to say, you're going well, nothing has happened in 1, 2, 3 years since your MI. We can probably remove this beta blocker and your quality of life may be better. But we needed a randomized study to be sure that the safety was also okay.
No, I think you're right. We had a lot of observational studies that supported the idea that stopping beta blockers, especially, as you say, years after having an MI event, may be a safe strategy. And I think a lot of patients are happy to be rid of some of their medications. But now come 2024, a big year for beta blocker research. So let's think about earlier this year and what we learned from the REDUCE MI trial.
So REDUCE is a trial which looked at the introduction of beta blockers at the time of MI when the patients are hospitalized for an acute MI, but there is no LV dysfunction, no heart failure, and the patient have, let's say, a simple MI going well. And they suspected, that was the hypothesis, that beta blockers would be better than no beta blockers, and they found the opposite. There was no real benefit of beta blockers in this type of patient. And this is what we had, but our study is very different. We are looking at patients who had an MI 3 years before, and they are still on beta blockers, maybe asking to stop the drug. And we have randomized these patients, 3,700 of these patients, for beta blocker removal versus continuation. And again, what we wanted to show is that there was no harm doing this, and we may also improve the quality of life, which is a big question for the patients.
So ultimately, what did the results of ABYSS show?
Exactly the opposite of our initial hypothesis. We were unable to show non-inferiority of this interruption of beta blockers versus continuation. Actually, we had an excess of events, numerically speaking, when we stopped beta blockers. So that was a surprise, and that was a safety signal. Of course, the study was open label. We had all sorts of beta blockers with different doses. It was very difficult to imagine to have a blinded trial, so it's a limitation of the study. But at the end of the day, when we look at death, MI, stroke, and rehospitalization for any cardiovascular reason, clearly the curves tend to diverge after 2 years, and we see an excess of rehospitalization for coronary reasons, mostly, when we stop beta blockers.
Well, I think that you make an important point there, that it was a broad composite outcome. Death, MI, stroke, not really much of a signal towards there being any increased risk of those outcomes with beta blocker discontinuation. But like you're saying, there was a profound effect on hospitalization for cardiovascular reasons. Yeah. So do we think that those were, anginal symptoms that were driving these hospitalizations?
That was clearly angina. It led to more coronary angiograms, also more PCIs. What we observed also is a poor control of blood pressure and heart rate in these patients, with a big difference. It was a 4 millimeters of mercury difference for the diastolic blood pressure. It was a 10 beats per minute difference for heart rate, we know that blood pressure and heart rate are prognostic markers for these patients. So I'm not saying that it clearly explains what happened, but we have to consider that heart rate, blood pressure were not controlled anymore when we stopped beta blockers. We had more angina. The study stops at 3, 4, for some patients, 5 years of follow-up, but the curves diverge. We would have 6 or 7 years of follow-up. I don't know what it would be, probably a significant difference.
And did you find that those differences in blood pressure and heart rate, were those sustained over time? Because you're talking about how those curves really continue to diverge. And do you think that that was driven by that persistent difference in blood pressure?
That's it's very interesting to look at it, because it happened very quickly after interruption of beta blockers, the rise of blood pressure and the rise in heart rate. And of course, the investigators had the possibility to adjust treatments, and they did it more frequently in the interruption group than in the continuation group. And despite this addition of drugs or increase in doses of antihypertensive drugs, we still had a difference along the follow-up in blood pressure and heart rate, a persisting difference of blood pressure and heart rate.
That's so interesting, right? Because in many ways, I'm sure that actually reflects real-world practice. But in essence, do you think there's any magical property, let's say, for the beta blocker in and of itself? If the blood pressure had been the same between the two groups, do you think that ultimately it would have been a neutral or non-inferior trial? Or is there an argument to be made that there is something about beta blockers inherently that would be different than, say, calcium channel blockers?
I don't know. Obviously, I don't know the answer to your question. What we can say is that clearly there was this effect on blood pressure, heart rate, more angina, and absolutely no effect on quality of life, which was what we expected as a benefit for the interruption of beta blockers. So knowing this, it's very difficult to say you can stop beta blockers in these very stable patients 3 years after an MRI, nothing is going to happen. What we see is different.
So I think the natural question is reconciling the findings from REDUCE-AMI now with ABYSS. And, I think that there are ways in which the two studies are consistent, because with REDUCE-AMI, as you said, this is now about beta blockers early after MI, no benefit on death, MI, or stroke, but similar to actually what you saw as well. You didn't see that those particular outcomes were being modified. But do you think it makes an argument for the idea that there is benefit for beta blockers early post-MI, despite the neutral findings of REDUCE-AMI, that had they had perhaps a broader outcome, as you did, that there might have been modification of other types of anginal symptoms, early revasc events? Or did the findings of ABYSS argue that had you never started beta blockers in the first place, that actually you might have been better about blood pressure control and, rather than a discontinuation strategy? So, what is the takeaway point?
It's all speculative, of course, but we have to keep in mind that REDUCE is a randomized study which looked at an administrative database. So they had death, MI. They didn't look at the other endpoints like rehospitalization for whatever cardiovascular reason. What we did with an adjudication of all the events. Now, if we compare the two studies, what is correct is that the two populations are very similar. And if you apply the message of REDUCE, saying no need of beta blockers in these patients, there is no more question of removal of these beta blockers 3 years later. So the removal of beta blockers applied to those who have had beta blockers early on. We have plenty of these patients, of course, at in the outpatient clinic. But you see, we cannot reconcile fully these two studies. If you do not introduce beta blockers, you cannot remove them later.
No, that's the real question, I think. Is it an issue of discontinuation, or was there no benefit for initiation in the first place? And I think that's, of course, the clinical question. So maybe that should be our final Question for you is, what are you going to do in your practice? If you have a post-MI patient, are you routinely starting them on beta blockers? Or do you feel like the data now suggest that, in fact, you really shouldn't be starting one at all?
I mean, it's difficult to say. Even in a simple acute MI, going to the CCU after reperfusion, I'm not going to give beta blockers in these patients on the basis of reduce only. So we still continue to give beta blockers to these patients. And now, 2 or 3 years later, we have to decide what to do with beta blockers in these patients. ABIS tells us that if the patient tolerates the drug and is not asking for a beta blocker removal very strongly, we should probably keep this drug on board, for the control of blood pressure, heart rate, angina. But the hard endpoints are not impacted.
Well, thank you for discussing this complicated topic. And
Yes.
I'm glad that there are still ongoing studies in this space.
Absolutely.
That will hopefully further inform upon what we should do as clinicians. But
Sure.
Thank you again for joining me today.
Thank you for having me.
Signing off from Medscape, this is Dr. Michelle O'Donoghue.